Hi, I'm Dr. Chan, and welcome to another CME video. Please watch the video till the end, and we'll provide details on how to get CME points. Thank you for watching.
Hello, good afternoon. Thank you all for spending your valuable lunch hour on Thursday. I hope you all are having a lunch and watching us. I'm very pleased to have another CME session coming to you from Subang Jaya Medical Center. And I want to introduce my friend and colleague, Dr. Khoo Kim, who is on my right. Sorry, which way? Hi, Kim. How are you doing?
Good. Thanks for inviting me, Alan. I really appreciate this opportunity to come visit and to do this talk today.
Yeah, all the way from USA, and it's very kind to talk on this interesting topic. I'll just change the layout now, and this is what Dr. Khoo is speaking on: diabetes care in the 21st century on insulin pumps and continuous glucose monitors. So the topic will, let me see, okay, navigate. We would like to invite questions at the end of the talk on Slido. So please join us on slido.com and you enter 3065317 in the code, and you'll be able to ask questions there. And if you want, you can also use a QR code scanner to take you to slido.com, and it will automatically log you into the question and answer site. I'm not sure whether you all are prepared, but if you can log in now, I've got a little questionnaire for you. Let's see whether it will work. Okay, so this questionnaire will be asking who is watching. Let's see if anybody responds. Yeah, if anybody is online now, can you log into Slido and vote? So we got a GP, okay, any specialist, or this talk is open to everybody. So even nurses, diabetic nurse educators, even patients who may be interested to learn more about insulin pumps and sensors. So feel free to vote. I think we are a bit curious to know who is watching. So about half GPs, half specialists so far. Yeah. Okay. Thank you for responding. So we will leave the questions till the end of it. We will be having Cpd points at the end of the talk. So it's again by QR code scanner, but using your MMA app, and you'll scan the QR code, which will present at the end of the talk. So I think without further ado, we are going to switch over to Dr. Khoo's talk. So I'll hand over to you, Kim, so you can take it from there.
Okay,
Okay.
thank you. Well, again, thanks everyone for inviting me and giving me this opportunity to speak. So today I'm going to be talking about insulin pumps and Cgms. I'm an endocrinologist at Mercy One Diabetes and Endocrinology Center, which is a medical system in the Midwest in Des Moines, Iowa. And I'll show you a map in a moment where it is. Now, I'll start off with some disclosures. So I have no financial conflicts of interest to disclose. I'm not paid by any device or drug company. So this is entirely my views. I'm not really here to sell or promote any single item. I'm from Malaysia. I still have family here. So I do try to come back every so often. And I'm a big fan of sharing knowledge. So I do like to do lectures. So yeah, I'm not paid by anyone to do this lecture. I've never practiced medicine in Malaysia. I have lived in the US for more of my life than I have in Malaysia. So I'm sorry if I say anything stupid because I really am not aware of the local procedures or options. As you know, Americans are stubborn. We have not adopted the metric system. So when I talk about glucose and the units that will be in milligrams per deciliter, so to convert to what we use over here, just divided by 18. The other funny thing is over there, we use the terms dinner and supper interchangeably. So if you hear me going back and forth, that's why. Okay, over here, supper is the meal you have after dinner. So I'm from Seremban. I did my A levels at Taylor's. I guess not too far from here. I think it's no longer here anymore. I went to IMC before it became a university. And then I transferred to the University of Calgary in Canada, where I graduated in 2001. I did my residency in internal medicine, followed by my fellowship in endocrinology at the Mayo Clinic in Minnesota. And I've been in practice at Mercy One since 2008. So Mercy One is a tertiary referral center. It consists of about 400 healthcare systems in the U.S. And the hospital is a mid-sized hospital. It has about 800 beds, 35 operating rooms, and 2 helicopters. So we have lived in Des Moines for quite a few years. My wife is an anesthetist there, and we have 2 daughters. So yeah, this is where we're located. Everyone knows about Chicago. It's probably the main metro area that's closest to us. So it's a 6-hour drive, and for us, 6 hours is actually a short drive. Okay, so objective today, really just to go over the newer technologies and equipment available for diabetes management these days. I realize that some of these are not available in Malaysia, but my hope is that with time, more and more of these options will be available to understand what they do, but also to understand what they don't do, because there are many misconceptions about what these devices do. To understand their role, though, it's also important to kind of have a background knowledge of the pathophysiology of diabetes. So I'm not going to spend too much time over this, but I'm going to talk a bit about pathophys. And I won't be talking about pancreas or islet transplants, but at the end, if there are any questions, I'm certainly happy to go into it. So as we all know here, the body requires insulin for glucose metabolism. Simply put, we just need insulin to be able to break down the glucose and to generate energy. Insulin is produced by the islets in the pancreas, but it surprises many to know that the insulin production is continuous. So we are making insulin all the time, even when one is fasting, we're still making insulin. When we eat, postprandially, our glucose tends to go up, so our body tends to make more insulin to compensate for that. We know that there is type 1 and type 2 diabetes. The truth is there's a lot of overlap between the two. Type 1 diabetes is a condition where there is absolute insulin deficiency. This is typically the result of immune-mediated destruction of the islets. And so the body is unable to utilize glucose for energy. So even if the glucose levels are very high, you're not able to use that to generate energy. So the body instead starts to break down adipose, leading to ketosis. So without insulin, type 1 diabetes, when it is full blown, is just not compatible with life. So prior to the discovery of insulin, 101 years ago by doctors Banting and Best in Toronto, type 1 diabetes was universally fatal, typically within weeks. So patients with type 1 must be on insulin replacement. You can do this in one of two ways. Traditionally, you can do injections. We call these the Basal bolus program or multiple daily injections or MDI, whereby we would use a dose of a long-acting insulin such as glargine. And at meal times, patients would usually count their carbs, estimate how much they would need, and dose themselves with a dose of a rapid-acting insulin like Libre and Aspart. Now, another option, which is becoming increasingly popular in the recent 10, 15 years, is the option of wearing a device called an insulin pump that continuously infuses one with a small stream of insulin. Now, in contrast, type 2 diabetes, there are multiple factors involved. I know that there was one time we used to think insulin resistance was the only issue. We now realize that it's a lot more complicated than that. Um, Insulin resistance is one of the initial triggers. This is typically associated with familial factors, obesity, lifestyle factors. In this situation, the body is simply resistant to the actions of insulin, so the body has to make more insulin to compensate for the difference. Now, initially, when one is insulin resistant, the glucose levels are normal. You are making more insulin, but at that time, a person is normal glycemic, you're not hyperglycemic yet. The problem is, as with the rest of the human body, we have a finite number of islets. We don't typically make more islets as we age. In fact, there's this age-related apoptosis where we lose more and more islets as we get older. So hypothetically, if humans all lived a few hundred years, everyone becomes diabetic eventually. But if you compound that with a state of insulin resistance where the islets are needing to work even harder, you burn out more quickly. So even with type 2 diabetes, it surprises many to know that it is a state of insulin deficiency, except unlike type 1, it's not 100%. This is a relative insulin deficiency. It's estimated that by the time a person presents with type 2, a person is down to 50, 40% of the pancreatic reserve or less. There's a reason why you'll find that with type 2, we often start off with oral agents, but over time, patients need to be escalated to insulin shots. So these days, we no longer try to force patients into a type 1 box or a type 2 box. We realize that there's some patients you really can't tell, there's so much overlap you really don't know. So perhaps a better way of looking at this is not necessarily two separate disease entities, but that type 1 and type 2 diabetes are on the opposite ends of a continuous spectrum, whereby in type 1, you make zero insulin. Type 2, you're making some, but as you get older, you make less and less and less. To compound things, the traditional testing that we would do for type 1, we could do antibodies for glutamic acid carboxylase or islet cell antibodies. We found that quite a significant number of type 2 patients may actually have positive antibodies. So a term that's commonly used is LADA, latent autoimmune diabetes of adulthood. So some would consider it to be kind of a mix in between. But regardless of whether you call this type 1 or type 2, the goal ultimately is the same. You want to control the glucose levels adequately while minimizing hypoglycemia and maintaining quality of life. But a few things to keep in mind is a true type 1 patient should never be without insulin. And I tell my residents and medical students, just because a person has type 2 doesn't mean you should put off insulin. If clearly, the hemoglobin A1C is 14%, the glucose is 400 or whatever it is, even it's here. There are some indications, even if it's type 2, clearly insulin therapy is indicated. Now, if we were talking about a full-blown type 1 person who needs 100% insulin replacement, the mainstay for the longest time is the basal bolus insulin program. So we use a combination of long-acting insulin such as glargine and mealtime or rapid-acting insulin during meals to compensate for the postprandial spike. Now, this remains for the most part the standard of care. But the problem with this program is while it works, it is very labor intensive. We were talking about at least 4 injections of insulin a day, and these patients are usually instructed to test the glucose 4 times a day as well. So if you think about someone on a long-acting insulin like Libre, because long-acting insulins work over 24 hours, typically we make adjustments to their doses based on their fasting readings. So these patients, we tell them you should be testing at least fasting. If you take a dose of insulin, such as part or breakfast, we typically make adjustments to this dose based on their pre-lunch readings. Likewise, the lunch dose is adjusted based on pre-supper readings, and the supper dose is adjusted based on bedtime readings. So that's the reason why we typically have our patients test their blood sugars 4 times a day. Patients will often ask, well, I checked my blood glucose last week. Do I need to keep checking it now? The answer is yes, because the human body is dynamic. It's kind of like how our weight is, it differs from week to week. Our blood pressure changes from week to week. So does our blood glucose and insulin needs. And so patients with type 1 diabetes are needing to test their glucose 4 times a day for the rest of their lives. So if you picture this, if you will, you have to load up your lancing device, insert a glucose strip into the glucometer to turn it on, clean the finger, take the lancet, prick yourself, squeeze a small drop of blood out and put it in the test strip. To have to do that 4 times a day for the rest of their lives, it is a lot to ask of our patients. And so we have waited for a long time to have a reliable continuous glucose monitor that may potentially replace this. And thankfully, there are some options in the market now that may do so. So this next section, I'm going to talk about the CGMs, and the last section, we'll talk about insulin pumps. So continuous glucose monitoring systems, or CGMs, are also called glucose sensors and glucose monitors. And what these devices are, these are devices that typically stick onto your skin. It is held onto your skin by means of an adhesive. Part of it will pierce the skin, so I'm not sure how well this shows up here, but typically the filament that pierces the skin is no longer than 1 centimeter, and it's certainly no thicker than the monofilament we might use for our foot exams. And so once this is inserted, it's meant to stay on for a predetermined period of time. Depending on the brand, it might stay on for 2 weeks at a time, or it might stay on for 10 days at a time. It measures the glucose levels within the interstitium, so within the tissue fluid here, and the readings are then transmitted to a receiver either continuously, so we call this a real-time CGM, or on demand. There are some CGMs out there where you would take the scanner, put it near your sensor, and then you see your readings. So we call that a flash CGM. CGMs have been used for a long time. When I was in fellowship over 15 years ago, they've been using it. But the problem is that they have been very unreliable. Accuracy was a concern. It was also really laggy. Part of this is biological because you are ultimately not measuring blood glucose. You're measuring glucose within the interstitium. So if you chug down a big glass of teh tarik, your blood glucose will go up first before it starts to seep out into the interstitium. And so you will find that the sensor readings usually will be a few minutes behind that of the glucometer. The older versions also have potential for drug interactions with some commonly used medications like paracetamol. It may falsely raise up the glucose readings. So for the longest time, the sensors were used not to replace the glucometer, but merely to supplement it. Perhaps for patients with severe hypoglycemia, unawareness, so they want that additional safety net to tell them what's going on. So this would be the populations who are using them. But for most patients, though, these devices were just not good enough to become mainstream. Over the last decade, though, thankfully, there's been a lot of improvements, and so we have sensors that are much more accurate. We have use of predictive algorithms that minimize the lag time, and the newer sensors are not typically affected by paracetamol. So in the US, we have several models available right now. The Dexcom G6 is a device that's worn for typically 10 days at a time. We have the Freestyle Libre, which I believe is available in Malaysia right now. We have the Eversense, which is the implantable Cgm, and they have the Medtronic Guardian. In the US, the Dexcom and the Freestyle Libre have both been approved by the US FDA to replace a glucometer. In other words, patients using these systems do not have to use a glucometer if they don't want to. Generally, it's good habit to have a glucometer handy to verify readings anyway, but if patients don't want to do it, they don't have to. So I'm going to talk a bit about the Dexcom G6. So this is not yet available in Malaysia. I hear rumors that it might be coming here. This is worn on the skin for 10 days at a time. It's approved for use on the arms. You can use it on the abdomen. So this here is a sensor. So this is typically stuck onto the skin by means of an adhesive. Stays on for 10 days. It then transmits to either a receiver, or these days everyone has a smartphone, so it can be transmitted to a smartphone, and it can also work with a smartwatch as well. So it's kind of nifty because I have patients who are able to see their glucose readings just by looking at their watch, not something that they could have done 20 years ago. There's some features of this that make it very helpful. You have the ability to alert the user if the glucose is above or below a certain threshold. The longer a person has diabetes, the less aware you might be of hypoglycemia. So all of us in the field have had patients who have no inkling that their sugars are dropping until they pass out and have a seizure. So having these devices can be lifesavers because you can set alarms that can warn you before that happens. The Dexcom also has the ability to share the data with family members, up to 5 users. And so I have some elderly patients whose kids are monitoring their blood sugars from afar. These things, unfortunately, are not cheap. So generally, the cost of the receiver is about $400. The transmitter will last you 3 months, and that's about $300 US. And a box of sensors, which will last you a month, is about 349. Right now, not available in Malaysia, but hopefully it will come here soon, so patients will have another option if they so choose. The Freestyle Libre is available here now. It came to the US market in 2018. I believe it's been used in Europe much longer than that. We had the original Freestyle Libre, followed by the Libre 14, followed by the Libre 2, and then the Libre 3. So I'll talk a bit about the features in a bit. But I just did a Google search, and it looks like you can find this on Lazada. I think you don't need a prescription for these things, right? Okay, so the Libre is a simpler system. The size is comparable to perhaps a 50-cent coin. It's approved for use only on the arm. So you insert it, you stick it on the arm. Again, part of it will pierce the skin. It's meant to stay on. Originally, it was 10 days, but these days the systems can be left on for 2 weeks. Once it's on, for the original system, to test the glucose, one would have to take the scanner, put it near your arm, and then you see your reading. So this is an example of a flash Cgm. So you would see your concurrent glucose level as well as the preceding 8 hours worth. So you can tell how your numbers trended when you were sleeping, for example. Not quite as helpful for patients with very brittle diabetes, patients who need that real-time warning. But for most of our patients, though, this was a very simple, very affordable way of replacing the glucometer. I realize it's still pricier than how much a test strip might cost. For most patients, you're talking about maybe $2.50 a day, but it's certainly a huge convenience. Okay, so the original Libre was worn for 10 days. The Libre 14 was a second generation. It was worn for 14 days, and you could use a smartphone as your scanner. The Libre 2, which is, I believe, the one that is available here in Malaysia, not yet. But I think 2 might be available. 2 will give you real-time warnings. So you put it on. To see your glucose readings, you still need to scan to see your readings. But you can set alarms where if your glucose is above or below that threshold, it will sound an alarm, will say, hey, you're hypoglycemic, scan yourself now. The Libre 3 was launched a few months ago in the US, and right now it's only now becoming available. And this is nice because it's actually smaller. It's the size of two stacked 10-cent coins, and it actually gives you true real-time CGM. So I have one on right now, and it's kind of interesting because you don't have to scan; you see your readings. So this is how my blood glucose looked a few days ago. This This was, I believe, Cgm Fun, and this was, I think, Pasamala. But it does make things a lot easier for our patients to have this option. The newer systems are not that affected by other substances. Paracetamol, I believe, if you're taking more than the recommended dose of 1 gram every 6 hours, it may falsely elevate Dexcom readings. Vitamin C for Libre patients, if you're taking more than 500 milligrams per day, it may raise your glucose readings by a minute amount, but really not a huge clinically significant amount. The Eversense CGM is also yet another option for our patients. This is the world's first implantable CGM. So it's not unlike the implantable contraception some women might have. It is an office procedure. We were the first in the state of Iowa to start doing this. It is something the size of a pencil lead. I'm not sure how well this shows up on the. So the sensor that we put into the arm is maybe 2 centimeters long, so slightly thicker than a pencil lead. And the original system was replaced every 3 months, out every 6 months. So what we do is patients come in for the procedure, we numb the skin up with lidocaine, make a small incision, and we would have a device. Once we have the incision and things are numbed up real good, we have this device that we would kind of place at an angle and then angle down and push in basically to make a tunnel for the sensor. And so once a tunnel has been made, we remove this and then we would use this applicator to insert the CGM under the skin and release it. And so this is left in place. Because the incision is so tiny, patients don't need stitches or anything like that. We just put steri strips, and after a few days, they're good to go. We tell them to not get the area wet for a few days and not to swim, but the recovery time is fairly rapid. So the sensor itself is under the skin. Over the sensor, they would attach a transmitter, which is about this size, and so it stays over where the sensor is. And so this detects the glucose readings from the sensor and transmits the glucose readings to the smart device continuously. The nice thing about this sensor is because it's under the skin, it's completely waterproof. You really don't have the risk of knocking it off. You might knock the transmitter off, but you can just stick it back on. It's easy enough. If you compare that to patients who are wearing the Libre or the Dexcom, if you happen to knock it off, you can't put it back on. You have to put a new sensor back on. So for patients, sometimes that becomes an issue. So though there are several different versions out there, they share some similar features. In addition to telling you the glucose readings concurrently, you're able to generate reports. You can look for trends. You can see if there's a certain time of day when you're running high, when you're running low. Some CGM systems even may suggest changes. If patterns are identified, it may suggest that, well, if you're having nighttime lows, think about making some changes in the basal insulin and so on. There's software that allows you to monitor things from afar. For example, patients with Dexcom or Libre, if they create an online account, if they're using the smart device to share, you can actually see their glucose readings almost in real time from a few hundred miles away. So when the pandemic was at its peak and clinics were shut down 100%, we reverted to 100% Zoom visits. It was fairly amazing because I'm able to see my patient's glucose trends from 2 hours away. So much so that many of our patients, after the pandemic got better, they still wanted to stick to Zoom visits because it was a huge convenience for them. So as far as benefits of the CGM goes, obviously it's a huge convenience. You're able to prevent severe highs or lows because even if you don't feel it, these things can sound a real-time alarm. Has been shown to improve the A1C without causing more hypoglycemia. And it also increases patient engagement. And I'm speaking out of personal experiences. A few days when I wore the sensor in preparation for this talk, kind of makes you aware that, oh, well, maybe I shouldn't have had so much nasi lemak, or maybe I shouldn't have had this much teh tarik, because you see the effects of certain meals, you see the effects of exercise on blood sugars. So indirectly, it does actually encourage better habits. Barriers, the main one would be cost, misplaced expectations. It gives you more data. It's not going to give you any additional, it's not going to take care of the disease for you. You have to decide what to do with that data. Sometimes you get too much data. So if you're not really sure, if you're scanning yourself too many times a day, you have so many readings, some of my patients get overwhelmed. And paradoxically, it sometimes causes patients to overreact. It is so easy now to check the glucose. Gone are the days where you actually have to budget how many test strips you have for a month. You test yourself only 4 times a day. These, you can test yourself hypothetically 100 times a day if you wanted to. So what sometimes happens is if a person has, say, lunch at noon, and they do a dose of prandial insulin at noon, they decide just for the heck of it, they scan themselves at 12:30 to see what happens, and oh, my glucose is a bit higher. Maybe I should give myself another shot of insulin. Scan myself again at 1:30, numbers are still high, give myself another shot. Not realizing that your noon shot's probably going to be in your system for another few hours. And so it leads to stacking of insulin. This other section I'm going to talk about is going to be related to the insulin pumps. So insulin pumps were first proposed way back in the 1970s. The original devices were huge. This is a picture of one of the earlier generations. Size of a backpack with tubes running all over. So it's kind of more an experimental thing than anything else. Um, the evolution of the insulin pump over the last few decades have been very slow. But in the last 10 years, we've seen a lot of rapid advances that make it a lot more popular, make it a lot more useful. Basically, an insulin pump is a pager-sized device. At least for those of us who remember what a pager is, it is maybe half the size of a cell phone, for example. And this device has a reservoir of insulin, depending on the brand. Alan, am I still on? Looks like I might be on. Action, Alan.
But you're still on.
Oh, yeah, okay,
You're still
okay,
on.
okay, okay, I'm sorry. Rancangan Tergendala. Okay, so they can still hear me.
Yeah.
Okay.
You're still visible.
Okay.
Sorry. Yeah.
All right. So these are devices that carry a small amount of insulin. Depending on the brand, it's usually 200 to 300 units in the reservoir. And these are connected to the patient all the time, either by means of an infusion set, so something that is inserted onto their tummy, that is a subcutaneous catheter here. And then there is a tubing that runs from that infusion set to the pump itself. So insulin is trickling through this continuously. Or there's also the option of a tubeless pump. The brand is Omnipod. So the pump itself is stuck onto the patient via an adhesive. And the pump itself is disposable. So once they're done with this, they toss this and put a new one on. And patients are controlling the pump using a wireless device. Because the reservoir typically lasts just a few days, these things need to be changed out. Either the Omnipod or the infusion sets need to be changed out every 2 to 3 days. Insulin pumps do not use long-acting insulin. They use only rapid-acting insulin, but in a continuous fashion. So by doing that, you're able to get, say, aspart and make it work like Libre. You can pre-program the pump with whatever basal rate you want. So the basal rate is the background insulin that's given all the time. And when you eat, patients are asked to estimate their carbohydrate intake and to tell the pump how much they're eating. The pump will then calculate a bolus and give a higher amount of insulin to try to keep the glucose from going up too high. So insulin pump is approved by the FDA for type 1 diabetes. It is also approved for certain type 2 patients, so patients who are on intensive insulin programs can potentially use the insulin pump as well. However, because the insulin pump has a small reservoir, again 2 to 300 units, it's really best for the insulin sensitive patient. My patients taking over 500 units of insulin a day would not be good candidates because you're going to be switching this out several times a day. There are numerous misconceptions about the insulin pump. Patients think that it's one of those fire and forget devices. You put it on and everything takes care of itself. But in fact, that is not true. Patients are expected to still monitor their glucose levels either by means of a glucometer or a Cgm. And you need to have some ability to estimate the carbohydrate intake and to operate the pump when you do eat. Now, some pumps do have the ability to sync with a sensor, and so the newer generation of pumps may be able to alter the basal insulin rate somewhat autonomously, but patients still need to estimate their carb intake and tell the pump when they are eating. Advantages of the pump. Overall, one would say you would have slightly better control, but the patient has to be willing to work at it. The truth is, if you put a wrong patient on an insulin pump, someone who is non-compliant, someone who is not able to count his or her carbs, pump's really not going to work better. In fact, there are studies suggesting that for some type 2 patients, if you put the patient on a pump, the A1C might actually get worse. Certainly a lot more convenient than the traditional needles. If you were out at the mama having a snack, well, you wouldn't need to physically expose your skin. You don't have to physically put a new pen needle onto your pen and inject yourself there. Instead, you can discreetly take your pump out, tell the pump I'm eating 60 grams of carbs right now. The pump can do the bolus for you. The pump will also calculate the dose for you. Most of our patients will have a predetermined insulin to carbohydrate ratio. For example, 1 unit of insulin to 10 grams of carbs. So for that patient, if you were doing the syringes, if you're doing the shots, if you were thinking I'm eating 50 grams, you would calculate, divide that 50 by 10, give yourself 5 units. Well, for patients on the insulin pump, the pump will do the calculations for you. The pump also has a protective mechanism to minimize overdosing. It has something called an active insulin time. It's going to remember if you had a meal at, say, 1 p.m. and you bolus at 1 p.m. and you have another snack at 2 p.m., it will remember that, oh, wait, you still have 3 hours worth of your last bolus, so I'm not going to give you all the insulin, I'm just going to give you part of it. So it does minimize the risk of hypoglycemia. There is also greater flexibility in the basal insulin dosing. If you compare a person on glargine 24 units, if you do a shot of glargine, it's in your system for 24 hours. You can't really make the glargine work better during certain times of the day compared to other times. But if you consider someone with differing needs, for example, a patient with untreated sleep apnea, perhaps exaggerated dawn phenomenon, a person who needs more insulin in the early morning hours, what you can do with the pump is you can pre-program the pump with, for example, a rate of 1 unit an hour from midnight, but at 4 a.m. you can increase the rate to 1.2 units an hour until noon or whatnot. So the changes that you can make is infinite. And so the nice thing is you can alter the basal rates for, if you have any specific needs. Likewise, if you tend to work out at 5 p.m. every day, you can decrease the basal rates during that time as well. So certainly using the pump it has been associated with improved quality of life. Connected pumps also allow doctors to review their trends and usage remotely. So this is an example of what we might be able to see. This is a patient wearing a Medtronic pump. You can see the glucose sensor readings here. We can also see when the patient was testing with the glucometer and what the patient was eating when the patient was eating. So in this case, the patient had a meal of 20 grams of carbs. The pump gave a bolus, probably a bit too much because the blood sugar dropped after that. So there's a lot we can see for patients who are wearing connected devices. The downsides, though, first and foremost, I think cost is a limiting factor for many, probably here in Malaysia. In the US, these things will cost about $6,000 for the device, and you are talking about a sizable amount for the supplies monthly as well. But in the US, most patients will have some sort of healthcare insurance, which is not cheap either. But if it's covered, if patients are insured, the healthcare insurance might pick up as much as 80% of the cost of the device. So it certainly becomes a lot more feasible for patients. Another problem is being attached to a device all the time. For some patients, factory workers, people who work with machinery, it might be an occupational hazard, the concern that perhaps the tubing might get kinked or stuck on something. Because the insulin pump doesn't use any long-acting insulin, the other issue is if you lose your infusion site, if your pump malfunctions, you are liable to go into diabetic ketoacidosis a lot more rapidly because you don't have any backup long-acting insulin. It's one reason why it's a good habit. Generally, we tell all our patients to have some long-acting insulin at home for times of pump failure. As I said earlier, the reservoir is small. The Omnipod carries 200 units. The Medtronic and the T-Slim carries 300 units. So patients who are very insulin resistant, it would not be a good option. And another disadvantage is just misplaced expectations. Again, referrals all the time from GPs, from other doctors. My patient is non-compliant. Please put this patient on a pump so that it will fix his diabetes. When in fact, that's not how the pump works. The current generations of pumps, though, patient input is still very important. Even with today's options, the pump is not completely automated. So we do expect a lot from our patients because they still need to count their carbs, they still need to input that um, into the pump when they do eat. Many studies comparing the insulin shot to the insulin pump does show some improvement, not a huge improvement as far as the A1C is concerned. So truth is most of the advantages of the insulin pump is more quality of life and lifestyle, not so much A1C lowering. So the current pumps, you still need the patient to count their carbs. They need to tell the pump when they eat, how much they're eating. Patients need to, some pumps will actually require glucometer readings to confirm. If you don't, the pump might revert back to manual mode. So truth is how successful a patient is has more to do with the patient than the pump itself. The options available in the US right now, we have the Medtronic 770. I believe in Malaysia it's a 780G. So the Medtronic pump has the ability to work with a sensor. And if you use it with a sensor, it is able to alter the basal rates. We have the Omnipod 5, which is a tubeless pump. So in this situation, this is a pump that's stuck into the skin. The pump is disposable, is controlled by a wireless device. And after 2 or 3 days, the patient tosses this and puts a new pump on. We also have the tandem T-Slim, which works with the Dexcom G6. Which brand is ultimately a patient choice? I tell my patients if I'm buying a car, it is really what they're looking for. But a few things that one would want to consider is how much would it cost. A lot of this is also dependent on which one the insurance prefers. What is the total dose of insulin per day? Whether you are looking for something that is waterproof or something that is detachable, tubeless versus a pump that uses traditional tubing, and the compatibility with certain Cgms. But I tell patients who cannot afford pumps, though, you really don't want to bankrupt your family, forcing yourself to go on a pump, because the truth is insulin shots remain the gold standard, and it does work very, very, very well. And so the pump shouldn't be seen as the best way of treating diabetes or a better way of treating diabetes. Rather, the pump should be seen as a different way of treating diabetes. And for some patients who cannot afford, insulin shots certainly work just about as well. So, in summary, we have many new options available for patients now. It doesn't eliminate the disease burden. There's still a lot of patients have to do, unfortunately, but it does minimize the work that they have to do. The pump provides a convenient alternative, but ultimately it is not a necessity. Patient still bears much of the responsibility, kind of. So I'll finish off with a few last slides here because there are continued changes. So as far as the insulin pump is concerned, the holy grail for type 1 diabetes is what we call a closed loop pump, a pump that is able to take care of itself without any patient input. So what we have is we finally have insulin pumps that are reliable. We have glucose monitors that are finally accurate enough. We now have pumps that are sensor augmented, so pumps that talk to the sensor, and the pumps can automatically adjust the basal insulin rates up or down automatically. But where we're at right now, patients still need to be able to bolus for their meals. What we are hoping to move to is a completely closed loop pump where the pump takes care of everything. Right now, such a system does not exist. But some of you might have seen this study that was published in NAGM just last week, actually. So I was quite excited to see this. So this is kind of a proof of concept trial, I guess. It was a shorter study looking at type 1 patients comparing a new pump system called the Bionic Pancreas made by a company called Libre. And they compared this to conventional treatment, which can be insulin shots or an insulin pump. But what's different about this system is that patients have minimal work. They don't have to count your carbs. They just have to tell the pump whether they're eating a regular meal, a smaller meal, or a bigger than usual meal. The pump does everything else. The pump calculates its own basal rates and the boluses. And at least in this short study, the A1C comparing this new pump to the conventional treatment was lower. So it's certainly exciting news because we have a system that might be one step closer to having a closed loop pump. And I think that's it. This is a picture of my daughters and my wife, Kristen, and our dog. My email address is there as well if there are questions later from anyone.
Okay. Thanks very much, TK. So that was a fantastic talk. We have in the audience some endocrinologists, maybe Dr. S.P. Chan and Dr. Hugh Fenley are here as well. I'm sorry we don't have the camera pointed at them, but that's okay. You have any comments? Otherwise, questions from the floor, you're invited. Either ask in YouTube or in Slido. Do take the opportunity now because TK here is live and ready to answer all your concerns and questions. If there are none, maybe I get the ball rolling. As a non-endocrinologist, just ask you it's expensive. Maybe it's just more convenient way to monitor and administer insulin using sensors and pumps. But what's the hard data that this versus conventional shots actually reduces complications in the long run? Is it worth it?
Complications, I'm not aware because complications, as you know, typically
diabetic complications. Yeah.
Right. Yeah. So usually, I think it'll be a while before we actually start seeing data on complications. But there's certainly clear data showing the benefits of the pump. I mean, if you're using A1C as the objective, the only target, which shouldn't be because there are many other important things that we have mentioned too. There is some data suggesting that the pumps might result in slight, not a huge, but slight lowering of the A1C. But patients definitely report much better quality of life. Many studies have also shown that it's associated with a lower rate of severe hypoglycemia, which is a big deal for many of our patients as well. So definitely, I think there are numerous benefits. But that being said, it is not a cheap system. So I tell my patients who are still choosing to do shots, don't feel like you're getting second best because shots still do work quite well.
Here, what's the usage here roughly? Let's say percentage of insulin-dependent diabetic SP. Any rough idea?
When you compare the Malaysian data, we have very few type 1 diabetic patients. Most of our patients on insulin are type 2 that require insulin for control, and they don't run into diabetic ketoacidosis if they should decide they don't want to take the insulin. But where I find the most exciting updates and innovations are in the Cgm options, because as you showed us earlier on, the Libre has been available in Malaysia a bit belated compared to the rest of the region. It was in the region, I would say, about 2 to 3 years ahead of us. We've had the Libre for perhaps 2 years, I would say. The pickup has been relatively slow because, again, as you say, the cost is a burden. It's 100% out of pocket, and insurance does not cover it at all. But I think that will eventually improve as it becomes more affordable. It does allow a lot of patients, whether type, I suppose most of us usually use it in patients who are taking insulin, whether type 2 or type 1. And it allows, as you say, them to be more aware of their lifestyle choices and how it impacts on their glucose, and allows them to realize, shit, I never knew this happened whenever I took this, like what you showed for your own experience.
Yeah, definitely.
And it helps them eventually adjust and improve. So quality of life is very much improved. And so the Cgm, I believe, is the way to go. Hugh?
Yeah, I believe so. In fact, a couple of my patients actually become more adventurous with food because now they can monitor every time they eat, which is less acceptable, which is more acceptable. So to some extent, it does allow them a lot more flexibility in their lifestyle. They don't feel that they are being encased or cocooned in a diabetes diet, which is a bad word to use in a lot of people. But we do know now that in terms of diabetes care, we don't have a diabetes diet. We just have a healthy diet. Low sugar, low fat. So the concept also changes because a lot of patients realize that some of the food that thought to be bad turn out to be not so bad. For example, rice is bad. That's not universally so. It's just how much you eat.
Right, I think that's key. Yeah, how much you
So it does actually give people an idea about not what kind of food, but it's how much you're eating. That becomes an issue with diabetes care, which has not really entered the sort of conversation that much because there is very little monitoring, or the monitoring is not complete. But with this, it's continuous, so we know from meal to meal what happens.
I guess one thing I would like to add, a lot of people might be wondering, does it hurt? How does it feel? So I've had this on my arm now for 3 days. I don't have diabetes, but in preparation of just wanting to get some data about my trends, I don't feel it. When you put it on, when you first put it on, you feel a bit of a pinch. But once it's in, I really don't feel it. Sometimes when I move my arm, it might feel like the skin is pulling or something, but once it's on, that's really close to zero pain.
Well, our experience with the Libre is they're surprised when we put it on. They say, "Is it done?" They didn't even feel it go in. So it's actually more fear, more psychological fear than the actual pain itself, and they hardly notice it's there.
I also had personal experience. I tried one. I
Okay,
can share with you. China made one.
Yeah, you told me that the last time we had this
China makes
conversation.
glucose
Coming,
sensors.
yeah.
They're supposed to last 2 weeks. Sticks on. You just feel like tiny prick, and it's really comfortable most of the time. But towards the end of 10 days, 11 days, I felt a bit of discomfort. I took it off. It was a little bit red at where the prongs were penetrated. I don't know. But anyway, it was fun because you could see when you take your food, you can see the glucose go up and down. Your nasi lemak, I'm sure like now after our nasi lemak, it will be going up and down. But yeah, it just provides very good feedback for.
I think the problem is that we are so far back. Libre, rightly or wrongly, has actually not given Malaysia any kind of, how would I say, they're so slow that we don't even have it available to be, to be sort of like synced to a smartphone. The patients have to have a sensor, whereas you are showing us that yours is coming through your smartphone. So even that LibreView has not been made available.
Are
So,
there third-party apps which can do this? I thought there are third-party apps which can connect to your Libre.
Yeah, I was gonna say probably VPN of some sort.
Yeah.
I would
we
say.
have to break whatever.
We are not an authorized
No, we
country.
don't. We
Yeah.
don't.
So that's
Not that
very
we are
sad.
officially recommending this, but
Yeah,
but
yeah.
yeah, I would imagine. Yeah.
Yeah, I know people have bought from Singapore, and some of my patients have bought from Singapore, but you can't use the app here,
Mhm.
which is, I think.
I think they promise us that if they
So those
purchase
from
it,
in charge of Libre, please get your act together and try to support Malaysian patients and get the app connected with the
it's
sensor.
a
Yeah.
headquarter problem. They
Yeah.
say that they just don't give us any priority. That's the word I was using for
Mm.
looking for. I mean, things like if it's available in the rest of the world, I don't see any reason why they can't make it available.
Right.
This Libre View, which is only a connection away, basically, it's not made available.
I think they don't watch out. All these China brands are going to
Are
come in.
coming,
They're
yeah.
coming. They're
They
coming.
are.
They're here already. They are here. There's actually local distributors.
I mean, I'm all for making things
Yeah.
simpler for patients. If
Absolutely.
if you have one less device to carry and you can use your smart device, I think that's great. I mean, everyone's got a smartphone these days.
Yeah.
And I say the uptake now has been suddenly just going up because the Libre people have become a lot more savvy business-wise to try and give them sort of like some kind of discount, so making it much more attractive. And as doctors become a little bit more familiar with it, they're also not so frightened to recommend it for their patients.
These things are not prescription, so a person can just buy it.
Yes, they buy it
You
off
can buy it
the
off Lazada.
Lazada.
Cheaper.
Or maybe Shopee. Whatever 10/10 sale coming on, maybe you get discount.
Maybe.
Yeah, but anyway, it's thanks for sharing. I think there's so many options, and I think as Malaysia becomes more sophisticated, people will be
I
demanding.
think this technology is
Yeah.
going to come and it's going to make a difference to the lives of patients with diabetes. What I would say that it allows the patient to be more engaged in
I
their own
think that's
care.
important. Yes.
Yeah.
Yeah. Okay. So let's check if there are any questions. I think everybody is watching with no questions, but it will be continued to be hosted, so you could share with your friends. I think there are some patients or nurse educators even watching this, and it will continue to be hosted. For those watching live, we have CPD points. Let's see with oh, okay, it doesn't show. I'm going to have to remove this and re-add to.
Perhaps I think Alan, you could say that if their interest
Mm.
in this has been sparked, maybe if they show that interest, we can get Dr. Khoo to beam across from when he goes home to give us part two. Because
Happy to do so anytime.
yeah, because I think it's a matter of, again,
Yeah,
getting
yeah.
more familiar, learning, and listening to more sort of practical tips as you've just given. You've given a very broad overview, but those individuals who are keen to try this on would probably benefit from getting sort of practical, day-to-day tips from yourself.
Happy
Yeah.
to do so.
Yeah. Okay. I've now flashed the QR code for CPD points. You guys can scan later. I'll show it on the screen. Let me check if it's working. This is how we get our
Your CME
points.
kind of
CME, yeah, which is now compulsory. We need 20 points a year.
Okay. So similar like what? Yeah, we need 20 hours as well for our license.
We don't have board with certification yet.
That's good. That's a good thing because
I'll test it for you.
Hold on. Okay.
Done.
Yeah.
Got it.
So when Dexcom becomes available to Malaysians, not
Okay,
that
I
I can-
tested it. The points work. So anyway, thank you all for attending and watching wherever you are, and thank you once again, Kim, for taking your time off on your, coming back home, meeting family, eating journey,
eating Jenny for sure.
and what. That's why you got your sensor on.
Yeah, exactly. Yeah.
The Cgm fan, yeah, whatever.
Well, thanks again for having me here.
Okay, so thanks for watching. The code will be on the video, and it will still be valid for about an hour. So you can still scan and claim your points if you're watching this late and not live. So have a good afternoon and rest of the week, everybody. And thank you once again for watching. All right.
Thank you for watching our video. If you enjoyed the content, please don't forget to hit the like button and subscribe to our channel. Also turn on notifications so that you won't miss our upcoming videos.
They will restrict like 1 month free. So if you happen to